Hi, I'm David Kornguth. I'm a radiation oncologist in San Francisco with Golden Gate Cancer Center. I've been treating primarily prostate cancer for the better part of 13 years, and I've decided to make a series of videos that help patients with newly diagnosed prostate cancer. This video is trying to help patients who have maybe just found out that they have prostate cancer or family members who are supporting somebody with newly diagnosed prostate cancer. Typically, this occurs because a patient had an increasing PSA, which stands for prostate-specific antigen, on a blood test that was probably done by a primary care physician as just part of normal screening. They go to the urologist. The urologist either orders an MRI or goes straight to a biopsy, and the biopsy is a sampling of different parts of the prostate, typically done under ultrasound guidance. Then you have to wait a couple days for the pathology report to come back. And if they find prostate cancer, even a small amount of the course, they're going to say that the patient has prostate cancer. Typically, patients in that situation sort of are tuned out because it's kind of shocking and the brain sort of just shuts down. And so it's helpful sometimes to have family members for that visit so that they can either take notes or maybe have a little bit more opportunity to think about things. In that first visit, the most important thing is finding out what the Gleason score is, because that's going to drive a lot of the next steps. The Gleason score is a measurement of how screwed up the cells look under a microscope from that biopsy. So it is a visual pattern. Okay, or sometimes we call that growth architecture. Normal prostate cells, when you look under a microscope, have this very classic homogeneous appearance, meaning that they look the same in different parts of the slide when you're looking under a microscope. As these prostate cancers become more mutated, more abnormal, they're going to actually look more like splotches of ink when you're looking under a microscope rather than sort of these neat little sort of circular patterns. And the more splotchy inky it is, the higher the Gleason score. The confusing thing is that we use several different terms to describe this degree of splotchy inkiness. The most sort of traditional one is this Gleason score. The Gleason score is based on sort of this grid that shows these pattern pictures looking from very sort of clean circular things at the top in pattern 1 all the way down to these splotchy inky patterns at pattern 5. And the sort of confusing thing is we give everybody a primary score and a secondary score. And we're going to add that up to get the Gleason score. So for example, if you look under a microscope and you see a pattern 3, and that's sort of predominant in one of the areas, one of the cores that you took, and there's a secondary pattern of 4, we're actually going to call that a Gleason score of 7. 3 plus 4. The number that's listed first, if the numbers are different, is going to be your primary score. If they only see, say, for example, a Gleason pattern 4, it's going to be a 4 primary, 4 secondary, 4 plus 4, 8. So the worst possible Gleason score that one can have is a Gleason score of 10, 5 plus 5. The sort of most favorable one today is usually either a Gleason 6, 3 plus 3. Sometimes they'll report a Gleason 5, 2 plus 3 or 3 plus 2. That's actually pretty unusual. Typically, we're not calling those cancer today. And that's a whole different sort of discussion about what constitutes cancer. But it's basically cells that have become mutated enough, they're on this non-reversible path of what we call dedifferentiation, which means getting more and more mutated over time. And the more mutated they are, the more dangerous they are, and the more they can adapt to sort of different environments like bone and that kind of thing. So the reason why this is such a big deal is that if one has a new diagnosis, say, of Gleason 6, 3 plus 3, that's actually stage 1, unless your PSA is very high or something like that. But basically, that's saying that there's a very low probability that it's spread to other parts of the body. And you have to confirm that. Sometimes the biopsies aren't as comprehensive as we'd like, and you may not have sampled the most sort of aggressive part. Bigger picture on this is that it's not unusual for guys to have different Gleason scores in different cores that were sampled. So some of them may be Gleason 6, some of them may be Gleason 7, and we're also always going to define the stage based on the most aggressive pattern. Why? Because that's going to be the thing that determines whether or not this thing can spread or not. In other words, let's say that you have 5 Gleason 6s that are sort of well behaved, but you have 1 Gleason 8. Well, that Gleason 8, when it spreads, that's the big deal, because what we're really worried about is spread of disease. That's really going to be the thing that drives whether or not somebody's at risk, their life is at risk from prostate cancer versus just having some local issues. So the other sort of piece is that if one does have a higher Gleason score, it's going to involve a more sort of thorough workup that might include things like a PET scan or a bone scan. And those are to determine whether or not the cancer might have spread into the lymph nodes or bone, but with this big caveat that we cannot see microscopic disease. This is something I always like to sort of hammer on home because it's sort of not intuitive to most of us. That what I mean by that is that a PET scan or bone scan can see collections of cells that are sort of sizable. But if you have microscopic spread, none of these scans are actually going to be able to see that. And unfortunately, there is not a technology today that can show us microscopic disease. So that's why the Gleason score is important, because part of the staging system is trying to communicate the possible spread of disease that we may or may not be able to see on any of these scans. And that's going to drive treatment decisions, because you always want your sort of cancer treatment to encompass all sites of disease from the get-go. And that would include sites that you know about, you might have seen on the biopsy, or maybe you saw it in the MRI, but you also want to be covering any potential areas that you don't see but are highly likely. And that might include areas that we call the extraprostatic space or extracapsular space, lymph nodes, or potentially even other sites. If you like this video, find it helpful, please like it, and I will be making more content. Thank you.